A person may feel mild pressure, interpret it as danger, immediately unload their knee, and conclude that kneeling is impossible. Another person may have enough motion to kneel but avoid trying because no one ever told them it was permitted. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle. A few weeks after her knee replacement, Maria found herself standing in her garden staring at the weeds she used to pull without a second thought. She hesitated, unsure if her new knee could handle kneeling, and worried she might damage something if she tried. That moment of uncertainty is something many people experience after knee replacement surgery. By the end of this episode, you'll understand why kneeling can feel so difficult after knee replacement, what the research actually says about safety and ability, and how a gradual practice plan can help you work toward this skill with more clarity and control. Kneeling is one of those activities that can highlight a gap between a technically successful knee replacement and how a person uses their knee in everyday life. You may be walking farther, sleeping better, and getting through the grocery store with less discomfort. Yet the idea of placing your new knee on the floor can still feel unreasonable. For some people, kneeling is connected to gardening, cleaning, home repairs, prayer, exercise, playing with grandchildren, working, or getting up after a fall. For others, it's not a daily priority. Either choice is valid, and it's important to understand that difficulty kneeling is extremely common after knee replacement and does not necessarily mean that you're physically unable to kneel. Research has shown a striking difference between what people believe they can do and what they can actually do when they are given clear instruction. A review by Wild and colleagues described kneeling as a valued activity that remains limited for many people after total knee replacement. Some studies have found that only a small portion of people report kneeling easily, even though many have needed to kneel during daily life. That doesn't automatically indicate a problem with the implant, the surgery, or your effort. Kneeling combines pressure, deep knee bending, skin sensitivity, strength, balance, and confidence. Any one of those can become the limiting factor. Let's start with the sensation itself, because the word pain can describe several very different experiences. When you kneel, the front of your knee takes direct pressure from the surface beneath you. Even without surgery, kneeling on a hard floor can be uncomfortable. After knee replacement, the skin, scar, small sensory nerves, and tissues at the front of your knee have been through a major procedure. Pressure that once felt ordinary may now feel sharp, hot, tender, strange, or simply unfamiliar. That is different from the deeper ache you might feel when your knee is bent, and it's also different from fear. Pressure is the contact sensation between your knee and the surface. Pain may come from sensitive tissue, swelling, the scar, or the amount of knee bend. Fear is the protective question that appears before you even lower yourself down. Could I damage the replacement? Could something move? What if I can't get back up? Those experiences can overlap. A person may feel mild pressure, interpret it as danger, immediately unload their knee, and conclude that kneeling is impossible. Another person may have enough motion to kneel but avoid trying because no one ever told them it was permitted. Studies examining kneeling after knee replacement repeatedly identify discomfort, pain, fear of harming the implant, and lack of instruction as common barriers. The barrier is not always a mechanical block. Numbness around the incision is also common. During a typical knee replacement, small superficial skin nerves at the front of the knee may be stretched or divided as part of the surgical approach. This can result in an area of reduced or altered sensation, often along the outer or lateral side of the incision. The size and intensity of this area may decrease over time, but some degree of altered sensation can persist. When a numb or partially numb area is pressed against a surface, it may not feel natural and can be perceived as thick, electric, prickly, hypersensitive, or somewhat disconnected from the rest of the knee. That altered sensory input can make kneeling feel less predictable. You place your knee down, but the sensation may not match your memory of kneeling before surgery. Your nervous system receives a new pattern of pressure and sensation, and the first response may be to pull away. With appropriate clearance and gradual exposure, repeated contact on a forgiving surface may help the sensation become more familiar. The goal is not to force numb tissue to feel normal. The goal is to learn what your current knee can tolerate safely. Now we need to separate implant safety from individual precautions. For many people with a well-healed, uncomplicated total knee replacement, kneeling does not appear to damage the implant. Studies of implant mechanics and postoperative kneeling have not established that ordinary kneeling causes loosening simply because the front of the knee touches the floor. But that general statement does not override your surgeon's instructions. Before beginning direct kneeling practice, clarify with your surgeon or physical therapist whether you're cleared to kneel and when it's appropriate to begin. Early kneeling is generally discouraged. The incision must be fully healed, and your care team may have additional precautions based on your specific surgery, tissue healing, or medical history. Some surgical approaches and implant designs may affect comfort or available motion, but research has not identified one design that guarantees easy kneeling for every person. A 2021 systematic review of surgery-related predictors reported that kneeling ability varied widely and was not explained by a single surgical factor. One of the most practical studies on this subject was published by Wallace and Berger in 2019. They surveyed people 18 to 24 months after total knee arthroplasty. Among the individuals included in the survey, 68% could kneel with little or no difficulty, even though they had received no special kneeling training. People who reported difficulty were invited to complete a 5-week graded kneeling program. Of those who completed all or most of the program, every participant reported being able to kneel afterward, and none reported significant difficulty. That result deserves both attention and restraint. It does not prove that every person can kneel, and not everyone who is eligible chose to participate. The group that completed the training was relatively small. Still, the study suggests that difficulty kneeling may improve with structured practice, even well after the early postoperative period. Individual results can vary, and patients should consult their surgeon or physical therapist before beginning a kneeling program. The published protocol progressed from softer to firmer surfaces. Participants practiced kneeling for about 10 minutes each day as tolerated. During the first week, they knelt on a couch. In the second week, they used a couch cushion placed on the floor. In the third week, they progressed to a thin pillow or thick carpet. In the fourth week, they used a thin carpet or rug. In the fifth week, the goal was kneeling on a firm floor or the ground, if comfortable and safe. That sequence is simple, but the details of how you enter and leave the position are important. 10 minutes does not have to mean dropping onto both knees and remaining perfectly still. Early practice may begin with your hands supported on a sturdy counter, chair, or bench, while you place part of your weight through the knee onto the soft surface. You can keep more weight through your arms and the other leg, then gradually allow the replaced knee to accept more pressure. A bed or a firm couch can be a useful first surface because it allows your knee to sink in slightly. Begin near the edge so you have something stable to hold. Step close, place your hands securely. Bring the involved knee onto the surface and pause. Notice whether you're feeling surface pressure, incision sensitivity, a stretch from your knee bending, or a deeper pain. Those distinctions guide the next decision. Remember, this is for educational purposes only. If the sensation is tolerable and it settles soon after you unload the knee, you may remain for a brief interval and repeat. If you notice a sharp escalating pain, new or worsening swelling that does not improve with rest, redness, warmth, a sudden loss in motion, or a sense that something is mechanically catching or giving way, stop and contact your surgical team promptly. A practice session should not become a contest between you and your knee. Progress can occur in more than one direction. You can increase the amount of weight through the knee. You can increase time, or you can move to a firmer surface. You can reduce hand support. You can increase the knee bend. Change only one variable at a time. That's generally best. Moving from a couch directly to a tile floor while also removing hand support makes it difficult to know which part might have exceeded your current capacity. Some people will be limited less by pressure and more by range of motion. Kneeling doesn't require the same knee bend for every technique, but lower kneeling positions usually require more flexion. You may be able to kneel upright with your hips over your knees before you can sit back toward your heels. Those are different tasks. Sitting all the way back is not the definition of successful kneeling. Others have enough motion but lack a safe way to get down or to stand back up. In that situation, the problem may be hip strength, quadriceps strength, balance, hand support, or confidence with floor transfers. Your physical therapist can help you choose a route that fits both your body and your surgeon's precautions. You might lower onto the non-operated knee first, use a padded bench, practice a half-kneeling position, or use a sturdy support to return to standing. The safest method is the one that you can control in both directions and that aligns with your postoperative guidelines. The 5-week graded kneeling protocol described earlier was published by Wallace and Berger. A second important study comes from Jenkins and colleagues who examined a kneeling intervention after partial knee replacement. The people who received education and kneeling practice reported better kneeling ability at 1 year. A partial replacement is not the same operation as a total replacement, so we should not treat the results as interchangeable. Yet the study supports a consistent idea. Education and task-specific practice can change what people report being able to do. That idea may sound obvious, but kneeling is often omitted from formal rehabilitation. People practice walking, stairs, getting out of a chair and bending their knee, then reach the end of therapy without ever placing their knee on a surface. Months later, they try once on a hard floor, feel strong pressure, and decide the skill is gone. A single test on a most demanding surface is not a fair assessment. Think of kneeling as a skill with levels. The first level may be touching your knee to a pillow while your hands carry most of your weight. Even individuals more than a year after a very successful knee replacement with strong leg muscles may still prefer or require padding and avoid hard surfaces while continuing to work on kneeling tolerance. A folded yoga mat, towel, or dedicated kneeling pad can make practice more manageable. Clothing also changes the experience. A thick pant leg, folded towel, gardening pad, or foam cushion spreads the pressure over a larger area. A hard, narrow edge concentrates pressure. Before you decide that your knee cannot kneel, change the surface and the setup. The timing of practice should follow tissue healing and surgeon clearance, not an arbitrary calendar. Early kneeling is typically avoided until the incision is fully healed and your care team confirms it's appropriate. The Wallace protocol involved people well beyond a year after surgery, so it shows that later improvement is possible. It doesn't tell us that everyone should wait that long. Some surgeons permit kneeling once healing is complete and the person can safely get down and up. Others use different timelines based on the operation and the person's health. Your response after practice is useful information. A mild tenderness that returns to baseline may be acceptable. A flare that lasts into the next day suggests the dose was maybe too high. Reduce the pressure, time, surface firmness, or total number of repetitions. There are also situations where kneeling may remain limited. Persistent stiffness, substantial loss of knee bend, patellar or extensor mechanism problems, complex revision surgery, skin vulnerability, neuropathy, severe balance limitations, or pain from another joint can all change the plan. A person with diabetes or reduced protective sensation needs particular care with pressure and skin inspection. Someone taking anticoagulant medication may bruise more easily. These are reasons for individualized guidance. If kneeling is personally important, tell your surgeon and physical therapist. Goals guide care. I want to garden. I need to kneel for prayer, or I want to get on my floor with my grandchildren gives your team more useful information than a general goal of getting stronger. They can assess the specific position, the amount of knee bend, the route to the floor, and the support you need. And if kneeling is not important to your life, you do not need to pursue it simply because someone says you should. Function is personal. The purpose of this discussion is to replace a blanket assumption with informed knowledge. For more practical education like this, the Total Knee Success Insider newsletter provides research summaries, clear explanations, and practical strategies for educational purposes only. It's intended to help you ask informed questions and better understand the factors involved in a knee replacement journey, and it does not replace medical advice from your surgeon or healthcare team. Check out the link in the show notes if you'd like to receive the newsletter. Kneeling after knee replacement can be difficult because it's not one problem. It involves pressure, sensation, motion, strength, balance, technique, and sometimes fear layered together. Many people can kneel, and some who initially struggle can improve through graded practice. Begin only after your surgeon or physical therapist has confirmed you're cleared to kneel. Ensure the incision's fully healed. Use a stable setup, start on a forgiving surface, change one variable at a time, and stop if you experience significant pain, instability, or concerning symptoms. Individual results are going to vary, and you should follow the specific guidance provided by your healthcare team. In the next episode, episode 94, we'll discuss stairs after knee replacement and why going down is usually harder than going up the stairs, including the role of the quadriceps, balance, handrails, and exercises that may help you prepare. Thanks for joining me. I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.